I'm Richard Winchelbaum. I'm a professor of pharmacology and medicine at the Mayo Clinic in Rochester, Minnesota, and virtually my entire career has been devoted to trying to understand the role of inheritance of genomics in variation drug response. We now have very powerful drugs that we use to treat diseases like cancer, but also heart disease, psychiatric disease, infectious diseases. And what we've learned in what I like to refer to as the therapeutic revolution that occurred in the latter part of the 20th century and the beginning of the 21st century is that individuals show very large variation in the way they respond to the same dose of the same drug. Most of them do very well. That's because the drugs were tailored for the average person. But as Dr. Francis Collins is fond of saying when he talks about the Precision Medicine Initiative, none of us are totally average. And the same applies to the way we respond to drugs. So what we're trying to do is to use genomic information to tailor the therapy, to individualize the therapy with a drug so that you get the right dose, you get the right drug for you. And what we're finding is that there are very, very large differences, and this can be very helpful. What we also know is that unlike some of genetic variations where the gene will be rare but can have profound consequences or relatively unusual, the kinds of variation we're talking about with regard to drug response are common. They're found in all of us. And an example that I use is a study that we did at the Mayo Clinic where we sequenced the genes that we know the body uses in order to get rid of a whole bunch of drugs. And when we did that, just for the top 5 genes out of a group of 84 that we looked at, 99.1% of the population in Minnesota surrounding the Mayo Clinic had a clinically actionable variant in one of those genes. So what that really tells me is, and tells all of us, is that we are all different, wonderful. It means that occasionally our species can produce a Mozart, but it also means that probably what is right for the average patient in terms of a dose of a drug or selecting the right drug may be different for each of us individually. And having that information ahead of time might help your practitioner to design a therapeutic program, a drug program that's right for you. That's what the hope is. Some of these very common variations can be quite striking. For example, I know all of us have heard of Tylenol number 3 with codeine. Our dentists were giving us that for pain for years. What I don't think most people understand is that codeine is not itself a painkiller. It requires that your body convert it to morphine. And a reasonable number of us can't do that. So when we get that codeine, it's a placebo. It doesn't work for us. Others of us can convert too much of it to morphine, and that's bad because we know that morphine can suppress respiration and can put you at risk for basically having an overdose. And I'll give you a dramatic example. And this did not happen in the United States. It happened in Toronto, where a mom had been trying desperately to have a child. In her early 30s, she had a perfectly normal baby. She had pain after the procedure and was prescribed codeine for that pain. The child didn't seem to be doing well in the first few weeks. She took the baby to the pediatrician, and the pediatrician said I couldn't find anything wrong with it. And the child was then found dead in its crib. When the mother's milk was analyzed, it had a very high concentration of morphine, which led to all kinds of, as you might guess, legal questions. But the problem was that the mom, her body took the codeine and converted too much of it to morphine. It ended up in her milk, and that resulted in the death of her child. This has been reported in the medical literature. Immediately, the group in Canada found other cases, and immediately the FDA and the Canadian health groups said don't prescribe codeine for moms of newborns. Now that happened early in this century, but it's a dramatic example that we can all relate to, where what everyone thought was a perfectly reasonable drug turned out for some people to be potentially lethal, not for them, but for their newborn children. I think every mom and dad in the world can relate to that. So these are dramatic examples, but they're examples that serve to make the point that we now, because of the advances that have been made in DNA sequencing, we're in a position to obtain the sequence information for the genes in your body, which your body uses to get rid of drugs, to convert drugs to prodrugs to active drugs, which is really what was going on with codeine. It itself had to be converted to an active drug. The same is true of a drug that's used in cardiac catheterization laboratories to prevent clots forming. The drug which is most widely used, a drug called clopidogrel, is it not itself a blocker of platelets forming clots? Now, if I'm the person who just had a stent put in, I want my drug to not let a clot form in my coronary arteries. And so once again, this kind of genetic information, if it's available at the instant that it's needed to your physician, could be immensely helpful. And that's what places like the Mayo Clinic and many other academic health centers are doing across the country, are trying to get sequence-based information using modern next-generation DNA sequencing to put preemptively in the medical record, and combining that with electronic alerts to the physician when he or she writes a prescription. At the current time at the Mayo Clinic for 17 drugs that we know genes can play an important role in their variation and response, there'll be an alert to the physician which will say, at the present time, would you like to order a genetic test? Now the problem with that is you have to wait for the test to come back. What we're currently planning to do in a collaboration with the Baylor Genome Center is to put that information preemptively in the medical record. So the alert to the physician will say, the patient that's sitting down with you right this minute has a genetic variation, which would mean you might want to alter the dose, alter the drug, or go to something totally different in terms of the treatment of this patient. So this is just beginning. Don't get the idea that this is standard operating procedure across the country, but what we see is increasingly this kind of preemptive approach toward making genomic information available to a physician at the point of care when he or she is writing a prescription is going to be at the heart of what pharmacogenetics will be doing, and eventually I think we will see this very widely used. Now we all know that the day is going to come when most of us will have our entire DNA sequence in our electronic medical record, hopefully protected appropriately from hackers so our privacy is maintained. At that point, we can just read this information off of the whole genome. But pharmacogenomics is so far advanced in terms of our understanding that we can begin by putting a panel of genes together, sequencing them, and putting that information in the electronic health record at a reasonable cost to try and prevent adverse drug reactions, maximize the good things that drugs do, and they do mostly good things, let me emphasize that. I've been talking about the bad things only to make the point that we want to avoid those bad things, and at the very beginning to select the patients who are going to do the best on that particular drug at that particular dose. One of the immediate questions that would arise is this cost effective? And at the present time, there are some preliminary studies, most of which, interestingly enough, involve the treatment of depression in psychiatry, where this is a terrible chronic disease. It's the #1 psychiatric disease worldwide, and yet lots of patients go from drug to drug and from dosage to dosage. What has been happening at the Mayo Clinic over the past 10 years is we've been providing increasingly to our psychiatrists this kind of genomic information as they prescribe the drugs. And what has been found in a series of studies, and I was not involved in any of those studies, so I'm just repeating what has been published in peer-reviewed journals. What has been found is that the rehospitalization rate for depression is reduced, actually in most of the studies, by about 50% in the first year. And the estimates of the cost savings in larger studies have ranged from $2,000 to $5,000 per patient in the first year. So as you think about the cost of doing the kind of sequencing that I mentioned just a few moments ago, the cost now is in the few hundreds of dollars and is decreasing. So it may well be that the cost effectiveness needs to be tested in each disease, but what we're going to find is the same enzymes that are important in psychiatry, some of these drug metabolizing enzymes, the way your body and my body get rid of these drugs, they will metabolize pain medications, medications that are used to treat cardiovascular disease, medications that are used to treat psychiatric disease. The enzymes really don't care what we use the drugs for. And so the information that you gain for psychiatry will actually be useful in cardiovascular disease. That codeine example that I mentioned, that same enzyme metabolizes a beta blocker, metoprolol, that's used to lower blood pressure and shows dramatic differences among patients in the dose of an antihypertensive drug. So this kind of information will have utility, clinical utility, cutting right across the boundaries that we place between medical disciplines. It may well be one of the first examples and the broadest examples of the application of genomics in a clinical setting. And we certainly hope so, because the goal is to prevent bad things happening. Doctors prescribe the drugs because they want to be helpful to their patients. They feel terrible when something bad happens. We want to avoid that. We want the good things that drugs do, like lowering your blood pressure and therefore decreasing risk of stroke and heart attack and renal failure. We want those to happen, and we want to stop churning in the system, having patients return again and again to have a different drug or a dosage change. It's possible that the implementation of preemptive pharmacogenomics will help on all these fronts, but the studies remain to be done that will show in a large population, such as within the VA system, that this is economically feasible. And of course, that equation is always changing as the technology changes and as the cost of DNA sequencing decreases.